Hello, this is Mary Hall from Carolinas Medical Center in Charlotte, North Carolina, and I welcome all of you today to the CAFM Advocacy Network webinar. And for the past 3 years, I have been the chair of AFMAC, and today I'll be your host. I'm going to let you know who else is on the phone as presenters today, and then review the agenda before turning it over to Dr. Tricia Elliott. So on the phone today is Dr. Tricia Elliott, who is the new chair of AFMAC, the Academic Family Medicine Advocacy Committee. She's at the University of Texas, Galveston, and has been the chair since last week at the STFM meeting. Hope Wittenberg, our government relations person from CAFM, is also presenting today, as well as Christina Kavanaugh from Florida State in Fort Myers, Florida, and Penny Beach from the Family Medicine Residency in Idaho, in Boise, Idaho. Christina and Penny are recipients of the new faculty scholarship for the Family Medicine Congressional Conference, which they attended last year. And they're going to each give some anecdotes and bring some color and life to some of the other information that we'll be sharing with you today. Before I review the agenda, I want to let you know that there is a chat box over to the right. I'm actually not sure if it's called that. Yeah, a chat box. And throughout the webinar today, I'll be checking that for your questions. There'll be several spots throughout the webinar in which we'll pause, and I'll have an opportunity to ask those questions, and we'll have an opportunity to discuss and answer them. But even if we don't get to all of them, or if time does not allow, we will be collecting all of your comments and questions, and we will be getting back to you with answers to those comments and questions. So please feel free to jump in there. Next slide, please. Today, through the course of the webinar, we are going to start with the basics and some definitions, which many of you are familiar with already, but to make sure we're all on the same page, with the definition of CAFM and the CAFM Advocacy Network. And then I'll turn it over to Dr. Elliott, who will say some more about the CAN Network and the CAFM Advocacy priorities. Hope Wittenberg will discuss CAFM's position on our legislative issues. Throughout, we'll have comments from Christy Kavanaugh and Penny Beach. And at the end, start with just a little bit of skill development. We have developed this agenda in response to a survey we recently sent out to CAN reps who asked for more of a focus on some of the legislative issues and priorities. But we still will end with a little bit of skill training and at least some opportunities for where you can get more information. So next slide, please. So this is a slide that shows all of the member organizations of CAFM and AFMAC. CAFM stands for the Council of Academic Family Medicine and is composed of the 4 academic family medicine groups: the Research Group, the Society of Teachers of Family Medicine, the Group of Residency Directors, and the Group of Family Medicine Chairs. With when 3 members of each of those groups come together with representation from the Academy of Family Physicians and the board, that makes up AFMAC. But backing up a little bit, CAFM is made up of the presidents, previous president, current, and next presidents of each of those groups, whereas AFMAC has different representatives from each of the organizations. The next slide is a different way to look at this, and again, these are the 6 member organizations of AFMAC. AFMAC determines the legislative priorities for academic family medicine. We determine those priorities and make recommendations to the boards of each of the organizations, and each of the boards votes independently. But the beauty of this process, which has been in place for several years, is that family medicine speaks with one voice, and academic family medicine tries to speak in one voice, and in that be in concert with representatives from AAFP and ABFM. So it's so far a great organization. So now I'd like to turn the program over to Tricia Elliott of the University of Texas, the current chair of AFMAC.
Thanks, Mary. It's a pleasure to be here, and thank you everyone for your participation on this webinar. I'm looking forward to being the chair of AFMAC and appreciate all of your support in doing so. As you see, we really want to thank you guys for participating and being CAN reps. We can go on to the next slide. If you take a look at this, as you can see with our residency programs represented across the United States, we have over 475 residency programs in the United States. The blue dots actually represent where we have current CAN representatives, and the green shows opportunities left that we would really love to expand our CAN network. Currently, we do have over 200 plus CAN representatives that are represented across the country, and we have 46 residency programs that are represented by these CAN reps. But we do definitely have an opportunity to expand that. So we're hoping that if there are any participants today who are not CAN reps and you'd love to sign up, let us know at the end of this webinar, and we'd be glad to help you sign up. Next slide actually depicts where we are with our departmental representation for family medicine departments. We have over 23 departments recognized now and participating in the CAN network. And these departments are actually members within the STFM. That was one of the organizations, academic organizations Mary mentioned to you, where we have the Association of Departments of Family Medicine by the chairs. These departments are not necessarily directly connected or affiliated with medical schools. They can represent other types of departments within other institutions and hospital systems, but they definitely are very viable and very important to us as we look forward to expanding the needs of our family medicine advocacy. Next slide. So I want to thank you all who participated in the CAN survey. It provided very valuable information for us, and we definitely want to hear from you all, and we want to go ahead and be able to address the issues. Here were some key items that came across as we collected the results of the survey. And I just want to go through them a bit with you, and actually we're going to use the opportunity for this webinar to be able to address some of that and hopefully answer some of your questions. When we looked at the results of the survey, over 50% of you really wanted to have a better idea of the family medicine key issues and really develop a way to frame those issues so that you could speak with your legislators more with more information. And so we're going to go ahead and give you an opportunity today to learn more about that, and we're going to frame our key issues today so that you can understand the best way to go about doing that. Also, 20% of you really wanted more skill development. And I'll talk briefly at the end a bit about the resources and tools available to you and how we can move forward. And if there is more that you'd like to hear from us, please don't hesitate to put a comment in the chat box there. And almost 70% of you said that you really didn't feel that you had legislative and advocacy success this past year in working with your legislators and your policymakers. And we found that quite interesting because I think one of the things is, how do we define actual success? And I think that's an actual way we can talk about what success is, because I kind of feel that there's probably a lot more of you that had success than you thought. And the remaining 70% also found that the newsletter was useful. Let's go to the next slide and talk a little bit more about what success is. So Zig Ziglar mentions that success occurs when opportunity meets preparation. And one of the things for us is that we don't really feel that success is always defined by having a legislative win, or if you had a bill passed or some policy passed. That's not necessarily the success we're looking for. The idea of developing relationships and preparing to do so and making those connections, that in itself is a success. So we're really looking forward to hearing more about how you are successful in building these relationships and informing your legislators and really making those connections. And we do believe that you guys are really truly making a difference, and we're really happy that you're participating with us through this network. As we go on to the next slide, I just want to kind of review again what the principles of advocacy, the principles are of advocacy. And most of us, we know this, but it's a really good thing to just review because you guys are doing this out there, and those of you that are not comfortable, we want to make sure that you build the skills to do so. So the idea of exchanging ideas is very important, providing information and education to your policymakers. You're providing them with vital information about our healthcare issues. You want to provide information about how it affects our patients, how it affects our practices and our communities, and also really key into how it affects their particular constituents. And really framing your conversation with them and having that opportunity to exchange ideas is key. In terms of educating your legislators, that's really also where you're providing that expertise. And they're looking to you as the physician who's connecting with them, and as a family physician, providing them the information that they need. And if we can continually educate our legislators and policymakers on the various primary care healthcare topics and provide our positions, that allows us to build those relationships and truly share our concerns and really build that trust. And it really is about building relationships and trust. And establishing these relationships from the very beginning is very key. And when the lawmakers actually identify specific healthcare topics, they're more readily willing to call you and call on you for your expertise and your opinions to help them build their talking points. So that relationship and that opportunity of building trust and relationships is a great opportunity for continuous exchange of ideas. And it's also important once you make these connections that you maintain them and sustain these relationships. Going to the next slide, and at this point we want to pause a bit, and I'd love to hear your questions and see if there are any questions at this point based on what we've talked about so far. And Mary, I'll ask you to see if there are any questions there at this time.
The one thing I'd like to mention is that there's been a little bit of conversation about people who know that they're CAN reps but don't see a dot on the map. So I just say, first I want to thank the Graham Center. That might not be the exact moment to have shouted them out, but I want to thank them for putting this together at the last minute for us. But apparently we have more CAN reps than we're seeing exactly on the map right here. So I just want to point that out. Otherwise, there have not been other questions that I've seen. Thanks.
Well, that's exciting to hear, and great. All right, we look forward to making more blue dots. All right, we're going to go on to the next slide. And we're going to get into our actual priorities right now with CAFM. And Mary defined to you already who makes up CAFM and what are the things that we are working on collectively moving forward. What are the academic advocacy issues moving forward? And Hope Wittenberg will be coming on later to really provide you more details on these particular topics. But we wanted to break it down into some real areas right now that are really active and must do. And you may have seen some alerts come through that are talking about these very topics. So the hot topics right now, for instance, dealing with Medicare GME, and we know that's always still a top priority for us. And we've added to that the reauthorization of the Teaching Health Center program. It's a program that supports a lot of our primary care medical residents, and it's a new way of training our residents within community settings. And we really want to make sure that we don't have a disruption of that pipeline of money to these primary care residency programs and training programs. So we have really, really identified this as a very key topic right now because we are at risk for losing funding for this program. And Hope will get into that a little bit more. But Medicare GME in other ways continues to be there also with the idea of workforce issues when we're looking at residency positions, looking at how we allocate residency positions for primary care specifically, how do we define that, and how do we ensure that we're having, if we're having expansions of residency programs, that we have a certain allocation to primary care, and how are we funding those positions. So we continue to make efforts with that and work collectively on that issue. And then, of course, about appropriations for programs that are already in place and some of our spending priorities moving forward. Title VII continues to be very important. Title VII is our primary care training and enhancement program, and it has been around a while, administered by HRSA, the Health Resources and Services Administration. And we are really looking to make sure that we appropriate at least $71 million to this so we can continue our training. And we haven't had an award since 2010, so we really are looking to hopefully open a competitive cycle with that as we move forward. And I know there may be some of you on the call who have benefited from Title VII grants, myself included, who this is a real key topic for. And we'll talk more about that moving forward and how to have that conversation with your legislator. Again, there's also research. Research continues to be expanded, and there are a lot more opportunities out there, and we're really wanting to look at developing a federal funding stream, particularly for family medicine primary care research. And there are two areas with regards we're looking at that. There is the AHRQ, our ARC, Agency for Healthcare Research and Quality, and we know that this organization is very key for us, and we'd love to make sure that there's an appropriation of at least $375 million appropriated here, because it's the only agency responsible for really providing that evidence-based research that we really rely on in our primary care so that we can provide the best care for our patients. And then there's also now the PCORI, or Patient-Centered Outcomes Research Institute, where there are opportunities here to be able to expand our research and really focus on patient-centered outcomes in primary care. Additionally, there are other things that are happening right now that already with the healthcare reform, ACA, that we're looking to work towards. Healthcare reform implementation, there are key things such as Medicaid, and we're making sure that was something that came up recently of trying to extend the enhanced Medicaid payment for primary care services beyond the end of this year, and we were hoping that we can see more of that and have that expanded. And that directly affects a lot of us who see Medicaid patients and provide that within the services for our patients and the services that our residents provide in our residency program. So that's some of those that directly affect us in the academic center. We want to make sure we're addressing that within healthcare reform also. Now, those are the CAFM priorities specifically, and there are other organizations that Mary mentioned to you, for instance, our AAFP or other organizations that take the lead on other issues that we know are still very important to us. Things around patient-centered medical home, payment reform as we're looking towards a combination fee-for-service or quality-based or pay-for-performance type of value-based purchasing, and looking at how we do that, and also the idea of ACOs or accountable care organizations. And we're happy to have the AAFP taking the lead on those issues. All right, we're going to go on to the next slide, and I want to actually do a bit of a poll question. We're going to take a little stab here of getting you guys to answer a question for us. And we'd like to see if you attended the Family Medicine Congressional Conference this year. If you did, yes, no, or do you plan on doing it next year? You can go ahead and vote at this time. And I'm also going to ask you guys that if at any time you have gone there, we'd love to hear your stories, and go ahead and submit that in the chat function there if you have any comments or stories that happened if you did attend the Family Medicine Congressional Conference in the last couple of years. We'd love to hear from you. And we're going to also be able to have Christy Kavanaugh, who's from Florida State University Family Medicine Residency Program, share her story. She's had some real success and experiences from this, and we'd love to be able to hear Christy comment on that. And actually, it's interesting, I'm looking at this, and no, the majority of you guys have not attended the Family Medicine Congressional Conference. So, Christy, I would love for you to just get the little spark under people and maybe inspire them to hopefully attend in the coming year.
Well, thank you so much for inviting me to share today about my experience at FMCC. As you mentioned, last year was the first time that I have ever attended FMCC, and it really, truly was eye-opening. I thought I'd actually focus a little bit more today on sharing with you some of the mistakes that I made as a novice to advocacy and some of the lessons that I learned from that through going to FMCC. I'll admit to begin with, I've never been politically inclined. Politics always seemed much too complicated for me, and I presumed that doctors who enjoy politics would speak up for all of us. Sometime later, I realized that a doctor who enjoys politics is more of an oxymoron, or at least a pretty rare bird. And so the decisions that are impacting our patients, the way we practice and the way we teach and recruit family physicians, are being made without a physician's voice. And so that really prompted me to get involved and attend FMCC to learn how to advocate for these issues. My next mistake was a fear that when I reach out to a legislator that I was going to be quizzed like a third-year medical student and not know the answer. So whenever I got an advocacy alert or an issue on some teaching or healthcare issue, I would spend at least 30 minutes painstakingly writing an email with evidence to back up my stance, with references and all, to send to my legislators. But this process was so time-consuming that I often just did not write a letter at all. Then my son's babysitter got a part-time job with our U.S. Senator's district office, and she shared with me that one of her responsibilities is to sift through the thousands of emails that he receives each day. So her job is to skim the letter to see if it references a particular bill or issue, and then adds a check mark to a database that puts it into the support or oppose column. Although I was a bit discouraged that all my work had boiled down to just a check mark, it did lift a great burden off my shoulders. So I realized that now I can spend 2 minutes writing a brief email that references the bill or issue and request that my legislator supports or opposes it. And it only takes a minute more to forward that email to my residents and fellow faculty and ask them to send it to their legislator. And that way my one check mark multiplies to 20. And I think that those 3 minutes are time well spent, and it's hard to argue that we don't have 3 minutes to advocate for these important issues. I think that my biggest takeaway lesson from FMCC was that as much as I am intimidated and confused by politics, the legislators are confused by medicine. They really don't understand what we do day to day and how their decisions impact us and our patients. And that's why they need to hear our stories. They need to hear how Mrs. McKenna's bad outcome could have been prevented through better access to care, or why we're having difficulty recruiting medical students into family medicine, and how their decisions on loan repayment and other incentive programs can help with that. And they need to hear how we want to bring more family doctors to our area to serve their constituents, and that we need them to support these teaching bills. That doesn't happen through an email. Even if I've spent 30 minutes on that email and if it's publication ready with references and all, it still doesn't share that story directly with the legislator. The most effective advocacy is through relationships, and FMCC gave me the opportunity to start building those one-on-one with my legislators. I recently had the opportunity to serve as Doctor of the Day for our state legislature, and I brought our chief resident with me. We happened to sit on the Senate floor while they debated a health care bill. My resident was astounded to hear the senators debate and ask each other medical questions and define medical terms, some of which were clearly not accurate. One senator even came over to us and asked us to clarify some of the medical terms and asked our opinion. My resident returned home all fired up for advocacy. She's been talking to anybody who will listen to her about how important it is that we share our stories and call our legislators, because they really are clueless about medical issues, but will be making the decisions with or without us. The conversations really need to be had long before the bill ever makes it to the floor for debate. And although we were not allowed to lobby while we were guests on the Senate floor or treating legislators in the clinic, it did give us the chance to meet people. We were able to give out our cards. We could offer to help them or their families to navigate the healthcare systems when they're back in their home districts, and offer to be their point of contact when medical questions arise so that they can enter the debate with more accurate information. So I strongly encourage each of you not only to attend FCC for that experience and to get the tools for entering into advocacy, but also to share your opportunities for advocacy with your residents and medical students. It will amplify your voice 100-fold when we all learn to speak up. Mary, have you gotten any other examples from participants in the chat?
Not yet. We are having a small technical challenge in that I'm not sure yet that I can see the questions. I'm seeing the chat of the organizers, but not the question box. But we'll figure that out. So in the meanwhile, let me introduce Hope Wittenberg as the next presenter, who will go through some of the details of our legislative agenda. And Hope's been with us for over 20 years, holds family medicine near and dear to her heart, even as close as we do. So thank you, Hope, and go ahead.
Thank you, Mary. So I'm going to talk just briefly about what's on our plate for this year. As Trish mentioned, in terms of our priorities, we have annual appropriations that we need to deal with for some key programs. We are trying to reauthorize the Teaching Health Center program. And then there are additional GME reform bills that are extremely complicated and we need more time than we can cover on this call, but that you can find out more information at stfm.org/advocacy. So I talked a little bit about the spending priorities for this year. And we have some challenges, and many of you may be used to using Title VII dollars for a lot of your curricular development and programs, and others of you, your program or department may not have money currently from this program. But historically, it's been very important to family medicine. And in the recent years, the dollars have gone down. So we are actually asking for $71 million for this program for the primary care training under Title VII, which is currently getting about $37 million. And so one of the reasons that we're asking for more than we currently have is that the current cycle of grants, which is a 5-year cycle, is going to be up at the end of this fiscal year. So we need new money because we have about 200 more grants that are being completed, and so they'll have an opportunity to reapply for new funds in a new competition. And then we also have folks that were left out of this for the last 5 years because there's been no new competitive cycle that also would like to be able to apply for these funds. So we're basically asking for an increase in the dollars so that we can use this money to move forward with areas of development that were basically included in the ACA, such as patient-centered medical home and a lot of development relating to value-based training, and basically training our students and residents in sort of a new health system as opposed to what we have had in the past. I'm going to switch to ARC funding, which is the Agency for Healthcare Research and Quality. And for this, which you can see it's a lot bigger, is about $375 million in base discretionary funding. And that's just a term of art, but it basically means is that's what we want the appropriators to use or to fund ARC at. And the reasons that we need this is ARC is very important to helping our country basically work towards the triple aim of safer health care, better health care, more accessible, equitable, and affordable health care. And ARC provides physicians with reliable information on how to deliver care more efficiently. It provides critical evidence reviews needed by physicians to answer the common acute chronic comorbid conditions that family medicine physicians see on a daily basis. And it promotes evidence-based patient quality safety practices. So all of those are reasons why this agency is critical to family medicine and specific and primary care in general in terms of moving the country forward. The next issue that I want to talk about is the Teaching Health Center Reauthorization Program. And this is a new program that was included in the Affordable Care Act. And to be honest, it's going gangbusters. It is really helping to increase primary care physician production and training in a new way. So what our ask is of members of Congress, both senators and representatives, is to reauthorize the program. Senators, there is a bill to reauthorize, S-1759, so we're asking senators to co-sponsor that bill. We're asking representatives to consider introducing legislation, either similar to the Senate bill or a little bit different, that would reauthorize the program. And additionally, we're talking about the need for a sustainable funding stream, such as Medicare GME, so that we aren't in the situation of every year or every 5 years going to Congress and saying, you know, this is a really good program, you have to fund it, you have to reauthorize it. And I'll talk a little bit more on this next slide about why this is a problem. So it supports an increased number of primary care residents. It trains them in community settings. The money goes to the entity that actually provides the training. It's the community health center, and the residency program is some sort of consortia, but it's not going to where it typically goes to a hospital. So the training, the control of the money, and the control of the practice allows folks to have more time spent in community settings. Now, the problem we're currently at is that the program runs out of money before this current crop of residents that will begin July 1 will graduate. So this cohort of residents, according to the current program, only has 2 years of funding left. And you know with the continuity requirements in family medicine, that third year, you can't just willy-nilly go off to a different program. So we want Congress to act now so that there is stability, so that the residents know that they have the funding for the last year and the programs know, and so that in the current fall recruiting season, we don't have problems because nobody's sure that the money is going to, if the money is going to be there. So that's why we talk about the need for sustained funding under Medicare to allow for stability so we don't have this problem. And when you're talking to members of Congress, to be able to say, you know what, this can be done in a budget-neutral fashion. It can come out of the Medicare GME. It doesn't have to cost the country more money, but what it does do is provide better training for primary care. So if we continue this program and allow for reauthorization, we're projecting an increase of about 400 primary care physicians annually, and the bulk of them, to be honest, are in family medicine. So that's what we are looking forward to doing. And I think from here, I will turn it over to Tricia to talk about when we make.
Can I jump in? Tricia, can I jump in for a minute?
Yeah, actually I was going to ask you, Mary, if you wouldn't mind. I know that we had some technical difficulties, so if we can actually take a pause and answer those questions.
That's right. Thank you. I just remembered you saw that as well. So we have our colleagues cutting and pasting from another place to give us some questions, and we have two. The first is a simple one. For those who joined late, what does CAN stand for, as in CAN reps? So simply to review, CAN is a CAFM advocacy network, CAFM being the Council of Academic Family Medicine. So those are, we have asked that there be a representative, at least one, if not more, from each residency program and each department that would gain expertise in advocacy issues, would join webinars such as this, and would be available for alerts, such as the one you see right in front of you, and will receive these alerts, know how to respond to them quickly, just as Christy so well described how quickly you can respond to these alerts and spread them around to your fellow faculty. We know that that is what legislators listen to. They pay attention face-to-face when you're in Washington, and they also respond to a connection and a relationship from somebody, such as these personalized emails. The second question is, I'll give a brief answer and then ask if any of my colleagues want to add to it. What patient care issues are on the CAFM advocacy agenda? For example, advocating for implementation of contraceptive coverage or advocating for states to take Medicaid, the expansions through healthcare reform. Two important issues. CAFM is the Council of Academic Family Medicine, so our focus, as Hope has just described, is indeed on issues related to academics and running our academic programs, and focus towards getting more primary care physicians in the workforce. That's the pipeline, and our attempts focus on getting more primary care providers out there, specifically family medicine physicians. However, what everyone learns when they go through some of the tools that we'll mention at the end, our online course, or coming to Washington for our Family Medicine Congressional Conference, they learn these advocacy skills and can apply them to any issue. So these skills are easily and readily transferable. So doing it with us, advocating for academic family medicine, you can then transfer those skills to the issues that are more pertinent to you and your specific patients. Also, the Academy focuses on issues that are more related to the delivery of patient care. Most of us are also Academy members, but our focus is on the academic issues. So back to Tricia or Hope taking this slide, or anyone else want to respond to that question as well?
I'll ask Hope. Hope, do you have any response? Anything else you'd like to add?
Well, no, I think Mary said it well, that by developing these skills that you can apply it elsewhere. I do think, and Christy kind of spoke to this, that sometimes at a local level, it's a nice way to start. It gives you you have easier access. Some of these folks are really in your neighborhoods, and you can talk to your state legislators maybe initially a little easier than you can your federal folks. So, for example, the issue of Medicaid expansion, that's where you live and want to work on that issue, then these skills will apply for that, and you can certainly take these, and they're portable, and use it for whatever issues you feel are important.
Great. Thanks, Hope. And Christy, I do want to thank you so much for your story. It was great and inspiring, and I hope it inspires others to really get active. As you see here in front of you, this is an example. Christy referred to it, and also Mary referred to it. This is what our CAN alert looks like. And so when you're a CAN rep, you'll get an email from Hope Wittenberg, and you'll see this email. And it's a very, very specific about the issue that we need to address at this time. And so, for instance, if you look at this one, this is dealing with the appropriations for Title VII funding. And we make it very easy why you can click on the action alert, and as Christy even pointed out, she was able to forward that on to her colleagues at her program, so it even kind of makes that exponentially more impactful. So we hope that you can take a look at this, and it's also very important that once you respond to this and you communicate with your legislators that you let us know that you responded to this, because it's very important for us to make sure we're following up and that we're helping you also to follow up on these and making those connections too. So thank you again, and hopefully as you guys hopefully sign up more, you'll be able to participate and take action with us. We're going to go ahead and actually do another question, and this actually just to kind of see where we are. We've presented to you our CAFM legislative priorities, and we talked about Medicare GME, teaching health centers, Title VII, research funding, but you may have other things too that are important to you. Some of you mentioned those already. So we'd like to hear from you. What are your department or program's legislative priorities? And you can select one, and we'll get a sense. And Mary, I'm going to ask you to comment on the responses as we move forward.
And I will take this moment while people are voting, if that's okay?
Yes, please, Mary.
While people are voting, there's a third question here, which is a great question. Hope, listen up. I'm going to ask you to respond. And you can see it too. Is there a Teaching Health Center Dear Colleague letter that we can reference when asking senators to co-sponsor? If so, where can we see the most current list of signers? So that is a really pragmatic, very useful question. I'll hold on the answer. And so Hope, if you could answer that actually while I look at the results here.
Sure, and that's a wonderful question. We do not have a Dear Colleague that has gone out asking for co-sponsors, but we do have talking points that we have up on the website, on the STFM website, under advocacy, so that if you are talking to someone and want to raise that question, some of the things that I just went over on the call are there, and you could explain to them, use those either in an email or whatever, explaining why you want them to support it. In terms of seeing who is a co-sponsor, I don't believe we have that up on the website now, but we can certainly do that. But basically the Library of Congress has all the bills up there, but instead of having everyone have to go look for that, I think that's what we will do, is we will update it and include who are the sponsors currently. And remember, in the House there are no sponsors. No one has introduced it yet.
Next question, a simple one, and then we'll go back to the slide in the poll. I am an STFM advocate, but does that make me a CAN advocate? And so, first of all, I want to say thanks for being an STFM advocate. I'm the president-elect, and I love all of you to join and be part of STFM. But if you signed up at STFM as some kind of advocacy advocate, okay, then that probably makes you a CAN advocate, but we'll check. And so we'll I think part of this work here is showing us that maybe we need to look at our list a little bit and make sure we've got it all right and have everyone listed so that we can send you the information that you need and let you help us help our patients. So this is interesting. If we have time at the end, it looks like Medicare GME slots is the highest priority for the people on the call today. So if we have a few minutes at the end, I might address that. We can address where we are with our work in that regard. If that's okay with everyone. Is that good, Hope?
Yes, sounds great.
Okay, so now I'll turn it over to Penny Beach, again one of our recipients of a new faculty FMCC scholarship award last year from Family Medicine Residency in Idaho. And even though there was not a dot in Boise, Idaho, Penny is a CAN rep. Penny?
Thanks, Mary. Yeah, I went to the FMCC for the first time last year. Unlike Christy, I actually have a long-time interest in politics. I guess I'm one of the few doctors that does. But I started my career as a newspaper reporter, and as part of that I did some political reporting. So I've always been interested in political issues and advocacy. So when I noticed this opportunity, I leapt at it. And I guess what I was a little nervous about is, I don't think this is going to shock anyone when I say that Idaho is a fairly conservative state. Our representatives don't really like spending a lot of money on anything, and a lot of the items that we were lobbying for academic family medicine obviously have to do with funding issues, and I wasn't quite sure how I would be received. But what I found out is that, first, Idaho's a long way from Washington, D.C., so my representatives seem to enjoy whenever anyone comes to visit them, and in fact, both of the U.S. senators took time to personally sit down with me and talk to me for anywhere from 5 to 15 minutes, which was just great. And they also were very receptive to hearing about how to solve problems that were specific to Idaho, even if they did involve more federal money. Idaho ranks 50th out of the 50 states in primary care doctors per capita. So when I go talk to them about expanding residency positions in Idaho, they're very interested and willing to listen. In particular, so the Family Medicine of Idaho, Residency of Idaho is a teaching health center, and we have several residents that are being funded through that program currently. And this is really an important issue for us because obviously it provides a lot of our funding. We're kind of fortunate in that we've been promised by the local hospitals if that money goes away that they'll kind of pick up the slack, but I know there's a lot of programs around the country that are talking about eliminating position if the teaching health center grants go away. In addition, I spent the year working on a project where I was trying to expand our residency by 2 positions by putting them in an underserved training track out at another community health center about 30 minutes west of Boise. And it actually turned out that we have a number of these rural training tracks, and usually they're funded by the increased patient visits that the resident sees. The problem was that this community health center has such a number of uninsured patients that wasn't going to work as a funding mechanism, and really the only way my my residency expansion project was going to work was through teaching health center funding. So that's been a really important issue for us that we're going to keep lobbying on. And I'll turn it back to you, Mary.
Thank you so much, Penny. That was really enlightening, and I appreciate your sharing your story. I have a question before we have only a few more formal slides to go through, so I'll say a question, and I think we'll have time at the end to respond to that poll. So this is just a comment, actually, and it's a great one. A thought that folks should get to know and develop relationships with the people who work in district offices. That is a great point. Things are local, and the people who work in the district local offices are not the same people who work in Washington. So getting to know both sets of folks who work with your legislators is a great idea, because again, we say it again and again, but it's relationships and knowing the people so that when issues arise and you pick up the phone, they'll know who you are and respond to you. So thanks for that advice. So turning it over now to how to prepare and conduct a Hill visit. So again, we said we spent most of our time on some legislative issues, and now have just a few slides on some skill development. Again, Hope, are you taking this one?
I'll actually take that, Mary.
Oh, sorry, Tricia. Okay,
yeah,
go ahead.
No problem. So we're going to go to the next slide. And this actually highlights our advocacy course that we have online. It's on the STFM website. And we'd love for you to go ahead and take a look at that at some point, and I'll tell you a little bit about how I utilize it within my own program. I'm a residency director here in Galveston, and as part of that, I actually conduct an advocacy workshop for my first-year residents, and I also conduct a 4-week advocacy health policy elective for my third-year residents. So I have a curriculum that I've built around advocacy and health policy. And actually, I start them in the first year with this very course, and anyone can sign up for this, and it only takes about 45 minutes to an hour, and really helps to fine-tune your own skills around how to conduct a Hill visit, how to understand the one-pagers, why are they important, what to expect when you actually get to a Hill visit. And as Mary said, these are skills that you can use not only on a federal level, but on a state level. And I love the idea that someone mentioned talking and making sure you develop relationships in the district offices. So same sorts of skills that you can utilize anywhere you make that connection with the policymakers. And so I use it as a part of our residency curriculum, and I have to say I've gotten great feedback from my residents every year. I've done it now for 3 years in a row, and we make it part of a 4-hour workshop. They have a lot of fun in actually doing some homework before we do the workshop, where they have to research and find out about their own legislators, federal and state, and make those connections. And we talk about that, and then we actually have a fun little activity where they have to actually conduct a visit, and we do a little role play there. And then we also do some role play as a team where they have to present before a Senate or House committee and testify and do a 3-minute testimony, and usually have faculty who are the senators and make it pretty tough on them, but a lot of fun. So I do think that this is a really great opportunity if you're looking for ways to really enhance your skills, but also to share with your colleagues and your residents or make it a part of your curriculum, that this is a great tool to incorporate in that. We are going to be taking a look at the course and enhancing it even further, and we're actually going to be looking at that and updating it. We want to include some of the more recent issues and examples, such as we've talked to you about with the priorities that are there now, and maybe incorporating some more real-time examples. And so we're going to be updating this in the fall, so be on the lookout for that, and we will notify you once that updated course is available. So I would definitely encourage you to take a look at that. We're going to go ahead, and I just want to get a sense of how many of you have actually taken the CAFM advocacy course. So we're going to go to the next slide. And how many of you have actually done this? And if you have any suggestions for improvement, we'd love to hear from you, and you can go ahead and put that in the chat or question box, and we'll take that information and definitely incorporate it as we seek to update this. And I'm going to ask Mary for sure, if you don't mind, when we get that poll question up there and the answer, if you can let us know, and then we'll move on from there.
Yep. And first, we do see the answer. I don't know if everyone can see it, but it says, have you ever taken the CAFM advocacy course? 20% have and 80% have not. And again, for all of us busy professionals of every type, when I took the course, first of all, it's broken into segments, so you can do a piece here and there, and it's just all of it's under an hour. So it's a really efficient, effective, pragmatic way to learn. So before you all talk, if you're going to see your legislators for any issue, jumping on that course would be very helpful to you. Let me, if it's all right with you, Tricia, let's talk back and forth. I might respond to that GME slot question, and then we have one more poll at the end. Is that good?
Yeah, sounds good.
Okay, so that is a major issue for us, looking at GME funding. The looking for increased slots has not been the top priority just yet, but there's lots of activity and conversation around that issue. So there are several bills before Congress right now about increased GME slots. And the reason we are not at this time advocating for one of them is because none of them actually include specific enough language that would ensure that the increase in slots would actually go towards primary care physicians. And that's our major issue. And we're working behind the scenes on some of those issues. So the bill language gets tricky, and that's where we count on our experts like Hope with the academic groups and Sean Martin with the AAFP to really help us with the bill language. Right now, some of you may know that in the past at least 10 years, the number of GME slots in the country has dramatically increased, despite the fact that there's not increased funding for them. So the hospitals and other entities are paying for those slots themselves, but they tend to be slots that go towards hospital needs versus the needs of populations and people. So we want to make sure that if there is an increase in funding for GME slots, that funding goes specifically and ensures that we have an increase in output of primary care doctors in general and family medicine physicians in particular. And most of you may know that of folks graduating from internal medicine programs, less than 10% are going into general internal medicine right now. Most of them are going to hospitalist programs or specialties. And so we have to be very careful to ensure that if people who graduate from family medicine and internal medicine programs, most of them go into primary care programs to meet the needs of the country. So in the country right now, about 33% of physicians are primary care, and we have good studies that say that at least 40 to 50% of physicians need to be in primary care to ensure high quality, decreased cost. And right now we're at 33, and with the people coming out of our programs now, we're heading down to 17%. So we are not going in the right direction. So we need more primary care physicians. The bills before Congress now will not make sure that that happens. And we, as a group of family medicine, the family medicine, not just academics, but all of the academy as well as the board, have come together with several conversations recently, have decided that before we put forth specific bills, and we will at the appropriate time, we want to make sure that the entire environment of Congress, Washington, the country, is ready to hear why they need more GME slots, and they're ready to hear that those GME slots need to be directed towards primary care and family medicine. Not for our sake, but for the sake of the people, which leads us nicely into the next question. The next, there you go. Another poll, our last, actually I think that's our last slide. How many of you have heard of the Family Medicine for America's Health Project? You can go ahead and answer that now. The reason I said that that was a nice slide in is because this, well, I'm going to let you answer first before I give you the answer. So this is, so most of you have not, and that's not surprising actually, because we haven't pushed it out in a big way yet. But this project is all about getting the environment ready to hear about primary care and family medicine, and it's about assessing the needs of our country for primary care. Now, is the answer more family doctors? Maybe. Is the answer teams of family physicians and advanced care practitioners, PAs and nurse practitioners? Maybe. Are the models of care, what models of care are necessary? This project involves the entire family of family medicine in looking at this issue and driving change in our country's health system. Tricia or Hope, do you want to jump in on that? And I'll look and see if we have other questions.
I would say I think it's definitely the next phase of what we're moving forward with, and we're going to be hearing a lot more about it, where there's going to be whole strategies and concepts around how we as family physicians will need to advocate for our patients and looking at our systems and looking at a broad-based system and looking at our own issues to be able to move us forward, and really how this will affect the outcomes for our patients and our communities, and really looking not only at population health, but looking at the impact within our other outcomes that we have. So it's a really broad-based, comprehensive project, and what I really appreciate about this, as Mary said, is that it's the whole family of family medicine coming together to do this and really making this a united national effort as we move forward in the next phase as we're trying to really advocate for family medicine and the health of America. And I know that we're going to be rolling that out, and hopefully if you're attending the AAFP's annual meeting in D.C. In October, you will definitely hear it in its full entirety and rolling it out, and it's a really great opportunity for us all to get involved, and we're hoping to incorporate even a bit of this in the next phase as we are looking at our priorities, advocacy priorities. It will definitely be one of them. And
I do want to link that to some of you some of you are too young to remember, but some of you may remember Future Family Medicine Part 1, which was in the early 2000s. And the Future Family Medicine Part 1 talked to people, businesses, colleagues, other professionals, and talked about family medicine as a discipline. We started this project talking about family medicine Part 2, and then realized, or excuse me, Future Family Medicine Part 2, and realized it should not be. That was the wrong focus. It's perhaps subtle, but very important. It should not be the future of family medicine. It should be family medicine for America's future and America's health. And so it feeds on work done 10 years ago, but links it to a better strategy, a much more, we hope, effective strategy. And yeah, that'll be talked more about in October. And I should have called on, I have another question that if somebody's read it and wants to say, I'm going to read it in a minute, but while I'm reading this next question, we have just a few minutes if Penny or Christy or Hope or Tricia have another comment.
This is Penny. I was just going to say that when you were talking about the GME money, that is one reason I'm so excited about teaching health centers, because they're a mechanism of funding that does increase GME slots, but it pretty much ensures that that money goes to training primary care doctors, because that's pretty much what you train in community health centers.
Right. So this is, for the last few minutes, this is a great, I don't know if I know the answer, but it's a great question out there. And again, I'll say, well, anyway, here it is. When talking to my U.S. Congress representative recently, they said that other organizations are lobbying to be called primary care. Of course. How does this affect our efforts, like neurologists and psychiatrists and physiatrists and rehab doctors and other folks who, this reminds me of the 90s when folks, for various reasons, similar reasons, wanted to be primary care. So when we do all of our work, I will say that we are very careful, and especially in the future Family Medicine for America's Health work, to define primary care based on the Institute of Medicine's definition of primary care. And that is the definition of primary care we use. And I, not having it in front of me, I can't quote it exactly, but it involves comprehensive, continuous care over a lifetime in the context of community, something like that. But it's the definition of primary care that drives all of our work, because the work that showed improved population health, improved outcomes with quality and decreased cost has to do with real primary care in comprehensive continuous relationships over time. So we do have to be very careful that all bills and our suggestions, that's actually a very practical example of why some of the bills before Congress right now aren't helpful, because they don't define primary care the right way. So we have just about 2 minutes left. Any of my fellow panelists wish to jump in?
Yeah, this is Hope. I'd like to respond also to that question. And first, thank you for talking to your legislator about that and having that conversation, because as you've noticed, lots of groups are out there claiming to be primary care. The issue for us organizationally is what is really primary care, but also what are the needs of the nation and the population. So we're not against having neurologists and producing more neurologists if they're needed for the nation, but it's really taking a look not at what the specialty may want in terms of developing help for their hospital or in terms of their staffing needs, but what does the nation need in terms of production. So thank you for having those conversations, and those are the kinds of things that Family Medicine for America's Health will be addressing in the future. And that's why I'm really glad that all of you are involved here, and that hopefully as we move forward with this, we will have a lot of work to do.
Right. Well, thank you so much. I know we're coming up on our time now. We definitely want to see if you have any more questions. Feel free to go ahead and put those in. If we're unable to address them right now, we're going to go ahead and collect those questions and definitely summarize the questions and put in some answers and let you guys know, hopefully within our newsletter or a direct email to our CAN reps and those of you who are participating on the webinar. I want to thank everyone. I want to thank Mary Hall. I'd like to thank Hope Wittenberg, and I'd also like to thank Penny Beach and Christy Kavanaugh for their participation, and all the organizers that helped us and staff in helping us to make this a very exciting and fun webinar. Thank you all for coming in and participating. To our participants, I want to, hopefully you've been inspired, and if you're not a CAN rep, I hope you'll sign up, and please let us know. We'd love to reach out to you. We'd like to, as I said, expand those blue dots and have more states represented. So we're looking forward to having you as a part of that. And if there are any types of other tools or resources you need from us, please don't hesitate to reach out to us and let us know. Mary, Hope, anything else to add?
Nope, that's it, Tricia. And I'd like to thank Tricia Elliott and for taking on Chair of AFMAC, and wish you much success for the next couple of years. Thanks.
Thanks a lot. Looking forward to
everybody.
it. Thanks, everyone.
Thank you, everyone.